patient, but there is some of the non-infectious issue.
Yes. So most important is when the
Sorry.
post
Hello, am I
engraftment.
audible?
Yes, yes, sir. Yeah.
There is a non-infectious entity that also keep differential diagnosis when we were dealing such a case. What is idiopathic pneumonia syndrome?
Yes. So these things actually happen after the engraftment is over. So as you have said, we have to keep whenever such cases come, we have to keep the non-infectious etiologies in mind. So when the patient actually first presented to us with hematuria, we were looking for other causes as well. And then when that lung was affected, things like idiopathic pneumonia, as you said, were in mind. So idiopathic pneumonia is, I mean, it is generally this, the alveolar epithelial cells get disturbed, and it causes a sort of pneumonia in these patients. What we also see is post-engraftment syndrome, in which the lung may be affected badly. There will be other symptoms of that as well. So differentiating these is very difficult. It's very tricky, in fact. So yeah.
Sir, we are running shortage of time. We have to conclude.
Yes. Okay. The session is very interesting, and I am thankful all the panelists and the speaker. Nicely you have presented the case, and thank you. Good night to all.
Thank you. And special thanks to Dr. Ramani is from California, for both the session. I know it is an odd time for you, but thank you, sir. And thank you all panelists. Special thanks to Jyotirmoy sir. Sir, we are sorry for the late due to the technical problem. So we will move to our next session, that is COVID vaccine and current understanding, because there is lot of confusion, lot of not only confusion, there is a fear is going on whether we will take and we will not take. So this session with us the eminent speaker Dr. S.K. Rajan, and sir is a senior consultant pulmonary respiratory physician in Bombay Hospital and Bhatia Hospital. And this session will chair by Dr. Dhiman Ganguly. He is an eminent physician in Calcutta, senior pulmonologist, and Dr. Subhasis Ghosh along with us. Sir, please start your session.
Okay. Before we start, I'm very sorry because it has run a bit late. Sorry, both Sujit as well as Dr. Dhimanda.
No problem.
Okay.
No problem.
Well, should we begin? Well,
please do.
Good evening. Good evening, Sujit. It's nice to see you after a long time.
Yes, likewise.
Telling you good night, but let's go to the evening.
Sure.
And I welcome all the delegates who are the patients to wait for 2 hours to listen to you. I hope there are many. Now, as we are, as usual, running short of time, it will suffice to comment as a preamble that there is a great deal of necessity of understanding COVID vaccines. Because so long we have the traditional approach to COVID vaccine, to any vaccine, was just 3 mechanisms, 3 technologies. You either have a live attenuated organism like oral polio, or you have an inactivated organism as in hepatitis A, or you have a component vaccine, component of an organism being used as a vaccine like hepatitis B. And now we are hearing about vector vaccines and mRNA vaccines. These technologies are not really new, but it was well known only to the research workers rather than practicing physicians. So over to you, Sujit, to explain to us these new technologies and what does it mean for practicing physicians. Over to you, Sujit.
Sure. Thank you, Dr. Ganguly. Thank you, Subhashish and Asif. Can you see the slides, Asif?
Yes, we can.
Sure, super. So My only conflict of interest is I've taken a single dose of Covishield at no cost. So, having said that, let's go across to some of the data. So, it's interesting to see some of the data on vaccines before they came in. An online survey last year actually interviewed people and asked them, would you take a proven, safe, and effective vaccine for COVID-19? And the overall average was 71.5% at that time, with the highest response rates in China and the lowest in Russia, which was less than 55%. This was in June 2020, and we know what our situation was then. A few months later, 4 months later, another online survey, which was presented at the World Economic Forum, of about 18,000 adults aged between 16 and 75 years, asked patients if I had a vaccine for COVID-19 was available, I would get it. And in total, about 73% agreed with that. Overall, vaccination intent which were not keen to take it, even if it was there, and in October. And if they looked at why vaccine hesitancy was there, this is also interesting because data has shown in the past that however agreeable the patient is to take a vaccine, if his physician tells him not to take, that's one message that needs to be understood by all of us, that if we don't recommend the vaccine, it's unlikely the patient will take it. And we may have our own reasons for recommending or not recommending it. The concerns of patients as to why they wouldn't take a vaccine was largely two things: side effects and speed of approval. 67% who were hesitant to take a vaccine said their concern was side effects. And this was Japan topping the list, followed by a bit of China and South Korea. 10% were generally against vaccines, so they were the non-approvers of vaccines, and 8% were these people who believed that they just couldn't get COVID, and we have all met such people. So those people will remain worldwide. So it's also interesting to understand the herd effect, and I know some of these messages are very simple, but I think many of my own colleagues sometimes have not understood what is herd immunity and how we get there. And herd effect is basically the amount of immunity needed in a population so that the virus does not transmit among people who are vaccinated or who have got previously infected, so that those who have no immunity don't get infection. That's the herd immunity. Now, for measles, we know we need a herd immunity level of 85 to 90%. Because measles has one of the hardest R factors, somewhere near 15. So measles is highly contagious. So you really need to vaccinate the population for that. Whereas it is estimated, but I don't think anyone still knows whether this is correct, that you need 65 to 70% herd immunity to get good herd effect. And how do you get that? You assume that the vaccine-induced immunity is 50%. So that means at least 50% of your population is vaccinated. Natural immunity, take it 15% as a conservative estimate, and you add those two together, you get 65%. So really, effectiveness and coverage. So if you have a vaccine that is 70% effective, and you can cover 70% of your population, you're there. So that's to give you a little perspective about it. And so obviously, if your vaccine, as you can see from this slide, is 100% effective vaccine, then you only need 50% of your population to get vaccinated. Whereas if your vaccine is 50% effective, you need the whole population to be immunized. So interesting data, and I always find this data, and I like this topic, and I thank Subhashish for allowing me to talk on it because I could read up about it a little more than I knew about it. A lot of candidates for vaccines, as you can see, a lot of platforms the spike gene, the attenuated virus, as Dr. Ganguly was mentioning. The live attenuated vaccine is not available for COVID, but there are, I think, 1 or 2 trials going on that. The vector vaccines, and of course, the new mRNA vaccine. So huge candidates across the globe and a lot of trials going on. I don't want to bore you with all those trials. But remember, when you identify the candidate disease like SARS-CoV-2, you start isolating the antigens, you develop a vaccine, and then you do animal testing for safety and response. And then you do human testing in small phase 1 trials initially with a few volunteers, 20 to 100, and then you move to larger trials, phase 3, before you apply to FDA or DCGI for permission. So the human testing, so what is the SARS-CoV-2? It's a cytoplasmic replicating virus. Positive sense is what it's called, single-stranded RNA, and it has 4 proteins, the S protein, which is the most important, the spike protein, the envelope protein, the membrane protein, and the nucleocapsid protein. So all of these are potential antigens. So we know the spike protein or the S protein has S1 and S2, which mediate receptor binding and membrane fusion of this virus. And the S1 has what is called the receptor binding domain, which binds to ACE2. And so it's antibodies to the receptor binding domain which have found maximum interest. And hence the S gene of the virus is the key target for vaccines. And the S protein, especially the receptor binding domain, it induces neutralizing antibodies and T-cell immune responses. And interestingly, the neutralizing antibodies have been shown last year in very good basic science research to correlate with the number of N protein species cells, specific N protein specific cells, which suggests that the neutralizing antibodies might actually be linked with activation of antiviral T cells, and that's very important. So we always thought that just the antibodies is not enough. You need the T cell immunity as well. Both are activated by neutralizing antibodies. And anti-sera to even M proteins also exhibit high neutralizing antibody titers. So you have the inactivated or weakened virus vaccines. They don't cause disease. They generate an immune response. They present multiple viral proteins for antibody responses, stable expression of antigenic epitopes, and this is easily mass-produced. You have the protein-based vaccines, which are usually harmless fragments of proteins of the virus that generate an immune response. And then, of course, you have the more interesting ones which have come to approval, which we will discuss. And this is the viral vector vaccines. It uses a viral vector that cannot cause disease, and the choice here is the chimpanzee adenovirus, as we all know. And for those of you who are not aware, the exposure to chimpanzee adenovirus in humans is very low. If you look at random populations, probably 1 to 2% of humans will have antibodies to chimpanzee adenovirus. A little more in sub-Saharan Africa, it approaches 10 to 20% because of their interaction with wild animals. So this chimpanzee adenovirus, however, is brilliant because you can actually grow it on a human cell line, which you cannot do with other vector vaccines. And the carrier virus, which is usually adenovirus, and it is engineered to carry the gene from the virus, usually the S gene for COVS, okay? So the immunogen, or the antigen, is expressed in the context of a heterologous viral infection, which induces the innate immune response required for the following adaptive immune response. We all have adenovirus antibodies, okay? And that's the, if I'm not mistaken, it's called the AD5 antibody. And so you obviously do not want an adenovirus carrying it, the human adenovirus, to carry this virus. So you need the chimpanzee adenovirus, for which we don't have the antibodies. And interestingly, even those of us who have chimpanzee adenovirus antibodies, even they will form neutralizing antibodies to these viral vector vaccines. So that's good news for even sub-Saharan Africa. Pre-existing immunity may also influence the T-cell immune response post-vaccination. The new vaccine, as Dr. Ganguly mentioned, is the mRNA vaccine, which uses genetically engineered RNA to generate a response that itself prompts an immune response, and it's delivered to human cells, and then transcribed into viral proteins. Very high potency. And this was the skepticism because we never had an mRNA vaccine in the world. You can develop these vaccines rapidly, cost-efficient production. Safety remains a concern because we haven't had much data. And I'll come to that at the last part of the talk. And then finally, DNA vaccines, which are also in trials, low-cost manufacturing, long shelf life. DNA molecules have to cross the nuclear membrane to be transcribed. So they have a little lower immunogenicity. They induce a type 1 Th helper cell response instead of type 2. So probably not so great. Only 50% had neutralizing antibodies with a recent MERS-CoV DNA vaccine. So if you look at mRNA versus the vector vaccines, we don't have the mRNA vaccine available in India as yet. The target is the spike protein. 2 doses are required with both. The storage requirements, however, are different, as we know. And if you look at these companies which have been doing studies, 2 doses, about 3 to 4 weeks apart. Moderna and Pfizer, we have read a lot about. I'll come to those. Inovio Pharmaceuticals is making the DNA plasmid type vaccine, 2 doses again. Most of the vaccines, except the Pfizer, is approved only for over 18 years. Pfizer can be given to even a 16 and 17-year-old. And Janssen Pharmaceuticals is doing a non-replicating viral vector vaccine, which is quite interesting. So what were the timelines? 8th December, emergency use authorization for Pfizer mRNA vaccine by the Medical Control Agency of the UK. So the first UK citizen got the vaccine somewhere in the 2nd week of December. 11th December, US approved the Pfizer mRNA vaccine. 7 days later, emergency use approval for Moderna mRNA vaccine by US. 3rd January, India had a restricted use approval for the AstraZeneca Oxford and the Bharat Biotech vaccines by the DCGI. And on the 16th January, sanitation worker Manish Kumar was the first person who was vaccinated. He was a sanitation worker at AIIMS, followed by a resident doctor, and followed by Dr. Guleria and Health Ministry official, of course. So that was a landmark date for India in terms of COVID vaccine. Just before I come to our vaccines, a little to understand about, because I know there are a lot of people from private hospitals, and we are going to soon have Pfizer and Moderna vaccines available in India as well, and we are going to have patients ask us questions. So it's 100 micrograms versus 30 micrograms. Both are intramuscular doses. The Moderna vaccine is spaced 28 days apart, the Pfizer 21 days. These are both frozen liquid. They require tremendous storage requirements, minus 70 degrees for the Pfizer vaccine. But the CDC is trying to look at a biological cold chain which permits even wider dispersal of this vaccine without maintaining such a strict cold chain at every center. Okay, and you have to mix it with a diluent. The Moderna vaccine is a little less stringent with 2 to 8 degrees once you open the vials, and minus 20 if you have to keep it for more than 6 months. These mRNA vaccines have shown great efficacy. I have to say, everyone was skeptical in the middle of last year, excuse me, but you looked at the primary endpoint was 95% protection 7 days after the 2nd dose with the Pfizer vaccine and with the Moderna vaccine, and you had 95%, almost the same with the Pfizer vaccine. Okay, and only about 7 few cases, the severe cases that occurred in the placebo group. So if you actually look at results after the 2nd vaccine dose, you can see that when you compare the Pfizer vaccine to the placebo, there were 162 cases in the placebo arm compared to 8. So that is great. Now, we don't know asymptomatic infection. That was the concern. How many people got infected but didn't have symptoms? If you actually look at the COVID-19 cases in the placebo group, between the 1st and the 2nd dose, 82, 2 to 7 days after the 2nd dose, 21, and 172 cases. Look at the vaccine group, the active group, and you can see they're markedly reduced numbers. So very clear efficacy, large numbers in the study, 20,000 plus. Likewise, if you look at the Moderna vaccine, again, significant difference between the mRNA group versus placebo group in the number of cases. Coming to the Oxford vaccine, which we have in India, this is a randomized single-blind control phase trial, which was done. Chimpanzee adenovirus vector vaccine. And you can see here, clearly the median age group that was vaccinated was younger, 35 years, 50% male. And the primary endpoint was the number of symptomatic virological confirmed COVID-19 patients, and of course, safety. And if you look at this, with a half dose of the vaccine given, followed by a full dose 4 weeks later, you had 90% efficacy, whereas 2 full doses 1 month apart gave 62% efficacy. So this has been the little confusion, and we had recent data a few days ago, but this data is changing every few days. So it's hard to give a talk on COVID vaccines, but it's good to update oneself off and on this. So 60 to 90%. And so there is some suggestion, and one of the principal investigators is a classmate, and I was talking to her, and she did believe that possibly if you have had COVID-19 infection in the past, you may want to take only 1 dose. I'm not recommending that, but it is a suggestion that you may.
Dr. Sengu, Samasi sir বসে আছে।
Sorry?
আপনি লিভ করলে লিভ করে দিতে।
Sorry? Asif, I think you need to just mute. Sorry, I thought you were asking a question. So the primary endpoint, as you can see from, so it's half dose, full dose 4 weeks later, we are 14 days later, and we are not sure, 28 days later, we are not sure really what this efficacy is, but it ranges between 60 and 90%. Recent data said even 1 dose may be enough. So this is interesting, and clinical trials have occurred in India on this vaccine. And again, over 18 years of age. No hospitalizations or severe cases were reported in anyone on the vaccine group. What is the safety of these vaccines? Now, with the mRNA, we have a little more data because that data came out earlier. The first 24 to 48 hours, we know local effects, pain, swelling, redness, occasionally fever, fatigue, headache, muscle and joint pain. And I can tell you that this was true for most of my colleagues in the healthcare profession who took the vaccine. 24 to 48 hours, fever and a bit of fatigue in at least 60 to 70% of people I knew, and minor local effects. Anaphylaxis with the mRNA vaccines, with 2 million healthcare workers vaccinated in the United States at the time of going to press, this was about a month ago, the incidence was 1 in 100,000. As compared to 1 in a million with other vaccines. So this is not to be taken lightly. And therefore, most of the patients who have an allergic reaction to either a drug, food, or a vaccine in the past have been advised not to take it. So the mRNA vaccine, the exclusion is really anaphylaxis to food, drug, or vaccine, or immediate allergic reaction within 4 hours to any of the vaccine components, which are polyethylene glycol or polysorbates in these vaccines. So we know that polyethylene glycol is in, before a colonoscopy, we give PEG, right? And that's in a higher dose than in these vaccines. And we know PEG can create allergic reactions. So that is possibly the cause of these anaphylactic or allergic reactions, but we are still not sure. Some of them are IgE-mediated, some of them are non-IgE-mediated allergic anaphylactic react, or what we call anaphylactoid reactions, where there's direct activation of the mast cells. Both of them respond to epinephrine. I see a huge market for the EpiPen in India. We still don't have it. And I really see people who do have a tendency to allergy carrying an EpiPen with them to the vaccination center. Not a bad idea, I think, because especially when you're hearing about these reactions in the US. So it's a lipid-based nanoparticle carrier system that prevents the mRNA vaccine of Pfizer, that prevents the degradation of the mRNA and facilitates in vivo delivery. That's further stabilized by a PEG 2000 lipid conjugate.
We are running shortage of time.
Yeah, I'll just take a minute, Asif. It provides a hydrophilic layer, prolonging the half-life further. PEG is possibly the culprit in the allergy and in both the vaccines, both Mrna and Pfizer. The implications for the adenovirus protein subunit vaccine that we have in India are still unknown. So to end, there are still a few unanswered questions. What are the correlates of protective immunity after natural infection or vaccination? How long will this immunity last? Will widespread immunity limit the spread of infection in our population? which component of the vaccine is causing the allergic reaction, and are some vaccines less likely to cause these IgE and non-IgE mediated anaphylactoid reactions. What we do know is the primary endpoint in the mRNA trial was symptomatic illness, and that was clearly prevented. Duration of vaccine immunity not known, long-term data awaited, and there are less than 200 participants per trial really developed symptomatic COVID-19. So it's too few to draw conclusions about the efficacy in a subpopulation. The SARS-CoV-2 genome, optimistically and interestingly, relative now, but we don't know really how this virus will respond to a selection process or the pressure of mass vaccination. Thank you very much. Sorry to exceed my time.
Thank you, sir.
Wonderful.
Okay.
Sir, we are moving to our next session. Actually, we are very shortage of time,
Yeah.
and this is quite late.
Go ahead.
Yes, thank you, sir. So
Okay.
next topic is current recommendation of anticoagulation in COVID patient, and our chairperson is Dr. PC Mondal. He's a head of the Department of Interventional Cardiology and in Apollo Clinicals Hospital, and he will introduce Dr. DJ Christopher, the eminent speaker. PC Mondal, sir, this session is yours, and we're running very shortage of time, so we have to conclude early. Yes, sir.
Good evening, everyone. I think this is an interesting topic. Just a small thanks to every one of you to include me in this session, because I was hearing these sessions, your sessions for last few hours. Really, really, really good. I will request Dr. DJ Christopher, head of the Department of Pulmonology of CMC Vellore, to start his lecture and without wasting any time, so that we can get at least few minutes to discuss at the end. Dr. Christopher, please.
Thank you, Dr. Prakash Chandra. I'm pleased to be invited to this meeting. So good evening to all of you, rather late good evening to all of you. I was just wondering, when I conclude, should I say good night or good morning? So I think I can say good night. Right. So what I'm going to cover in my lecture quickly is what is the incidence of venous thromboembolism in COVID-19 patients. Is anticoagulation proven to improve survival? Does the intensity of anticoagulation change outcomes? What are the adverse events with anticoagulation? What is the recommendation for anticoagulation? So this is a systematic review. It was published somewhat early, which showed in 17 studies involving 1,913 patients that venous thromboembolism was 25% in hospitalized COVID-19 patients. And severe patients had more, 3.76-fold higher risk of venous thromboembolism. And also, this study showed that probably pharmacologic thromboprophylaxis was associated with lowering incidence. So this is another study that showed in ICU patients. Now, ICU patients have particularly more risk of venous thromboembolism. They were also on prophylaxis. Even so, 27% had evidence of venous thromboembolism, and 3.7% had evidence of arterial thrombotic events. This is another hallmark of this disease, that patients have arterial microthrombi. This is a study of 198 hospitalized patients who again were on routine prophylaxis. Despite that, all venous thromboembolism was seen in 42%. And if you look at the ICU patients, it was 59%, but the ward patients, it was 9.2%. Symptomatic venous thromboembolism, 25%, obviously will be higher in ICU, 34% versus 9.2% in the ward. Now, how does venous thromboembolism and a prothrombotic situation happen? And what is its role in the respiratory failure that we see in COVID-19? So this is a schema of the SARS-CoV virus, and we know that it takes the ACE2 receptor route to get into the body. And TMPRSS2 is a host agent. It is a part of us, but this is the one that allows the virus to cleave and get into the system. So through the type 2 pneumocytes, it causes damage and therefore respiratory failure. It works on the macrophages, neutrophils, lymphocytes, and other immune cells, and it causes inflammation. And it works on the endothelium, causing endothelitis, so inflammation of the endothelium. And this initiates coagulation cascade leading to microthrombosis. So all these factors are crucial in the respiratory failure in COVID-19. So if you recall, Virchow's triad is the basis for hypercoagulation or venous thrombosis. And this hypothesis is more than 100 years old and still holds very true. The three components are the three factors that cause hypercoagulable situations are endothelial injury, stasis of blood, and a hypercoagulable state. In COVID-19, all these factors operate. There is endothelial injury, as we saw earlier. There is immobilization in hospitalized patients, which causes stasis. And there's a hypercoagulable state due to several mechanisms that I have listed here, which we do not have time to go through. And therefore, it falls within our scope of understanding that COVID-19 could cause venous thromboembolism. So let's look at some pathologic studies. Some early pathologic studies came up with startling findings. So this is 12 consecutive COVID-19 patients. Autopsy revealed 58% of them had venous thromboembolism. And of these, in 4, that was the direct cause of death. This is another autopsy study. Again, I'm not going to go through the fine print. What you see here is arterial thrombus. And even these are called microthrombi. So basically, what they didn't expect in autopsy is that there would be thrombosis in small and medium-sized pulmonary arteries. So this is a unexpected finding and somewhat peculiar to COVID-19. So this is this is again the autopsy study where they showed that the capillary microthrombi were 9 times more prevalent in COVID-19 than in other influenza. So this statement particularly answers a question: is this seen in all these patients who become sick anyway, regardless of what etiology it is? Is this peculiar to COVID-19? So this study actually shows that compared to other viral respiratory infections like influenza, some people do get sick, but the incidence of microthrombi is much higher. So how do we treat COVID-19 associated coagulopathy and how do we prevent it? Unfortunately, there are no large randomized controlled trials that either support either standard prophylactic or intermediate dose prophylactic or therapeutic anticoagulation. Most of what we have are retrospective case series, and well-designed studies will take time, and we do not have those yet. So a balanced approach is that, well, if there's high mortality, then we should be careful. And so we should take appropriate prophylactic and therapeutic options. The second factor is absence of evidence of benefit, which is what we face now, is not evidence of absence, which means just because we don't have studies, we cannot exclude these as not being useful. On the other hand, we have to follow this basic principle enunciated by Hippocrates: first, do no harm. We should not put patients through any treatment that may cause harm. So let us look at some of the trials that established its role. So this is a trial that looked at 28-day mortality between prophylactic heparin users and non-users. And they showed that the difference was 30.3, 29.7, which is not different. But 28-day mortality of heparin users was lower than non-users in only a subset. So overall, there is no difference. But when people have sepsis scores of more than 4 or D-dimers more than 6-fold of upper limit normal, then the mortality is different. So is heparin useful from this study? It is useful only in a particular subset of patients. And this is another study that compared standard prophylaxis. So standard prophylaxis is 40 to 60 milligrams per day, and intermediate prophylaxis, which is 40 to 60 milligrams enoxaparin twice a day, and for 7 days. The intermediate low molecular weight heparin, the intermediate dose, which is higher than the standard dose, was associated with lower in-hospital mortality compared to the standard dose, which is 18.8% versus 5.8%. So you tend to think that rather than give the standard dose, you give a little higher. Now, this is data from the ICU, where they have given therapeutic dose. And there again, they showed that compared to prophylactic dose, the therapeutic dose was significantly better. So it was associated with less mortality. So if you give prophylactic, mortality was 86.2, therapeutic it was 63%. So many people use this evidence. It is retrospective, it is not randomized controlled study, but they used it and made this practice, and many ICUs gave therapeutic anticoagulation. So this is a study, obviously a large study of 4,389 patients. They looked at mortality. Now, remember, so far we looked at several studies that looked at events, the procoagulant events. But here we are looking at mortality. Interestingly, they found that the hazard ratio for therapeutic and prophylactic were equal. There was no difference between the two. And they also showed that if it is initiated less than 48 hours, there is no difference between therapeutic and prophylactic. So what they are saying is both have equal efficiency, especially if it is used early without delay. And even in this group where anticoagulation was given, 42% had thromboembolic disease not clinically suspected, and 27% were on therapeutic anticoagulation, the highest dose that we would give for people with established venous thromboembolism. Now, so we have looked at some data that supports the fact that anticoagulation is helpful. I just want to show you some other data which is conflicting. So this is a meta-analysis, and we know meta-analysis are much stronger than one randomized clinical trial or retrospective study. So here it looks at several studies and takes the pooled effect. So each study, this is the effect, which means if it is on this side, it means that the outcome is worse. If it is on this side, then that means it is better. So you see almost all the studies are lying along the line, which means they are not very much better, not very much worse. And this is the cumulative effect, which is again lying in the midline. So this meta-analysis showed that in moderate, so the prophylactic heparin was not associated with a difference in mortality. And in moderate COVID-19, the relative risk was 0.87 and severe it was 1.07. If you know statistics here, you can, it means that neither of this is actually clinically significant. So should we consider prophylaxis in COVID-19 patients, the same meta-analysis? they found a positive effect of prophylactic heparin in patients with moderate symptoms and in patients whose D dimers were high and also whose platelet count was high and PT was low. So this is the subgroup in which they found that the effects were better. Now, how about adverse events? I said right at the outset that we should first do no harm. So this study showed that the major bleeding, not minor, major bleeding with therapeutic was 3%, with prophylactic was 1.7%, and with no anticoagulation it was 1.9%. So prophylactic dose does not seem to give any additional harm, but therapeutic seems to have higher major bleeding. So if you sum up the bleeding risk, observed bleeding prevalence in patients with COVID-19 receiving high dose thromboprophylaxis is twofold higher than patients receiving standard dose thromboprophylaxis. But this is lower than patients who receive therapeutic dose. In other words, higher the dose, more the risk of bleed. And the safest seems to be the standard dose thromboprophylaxis.
Well,
so major bleeding occurred 2 weeks after hospitalization, and dose de-escalation after the first 10 to 14 days should be considered. Maybe it's prudent to think about it because that is when this side effect is manifesting more. Okay, so finally, we have two schools of thought. COVID-19 is a prothrombotic state, but yet there is evidence to support COVID-19. The evidence to support COVID-19 as a prothrombotic state is also not completely foolproof. So what did we follow? So this is the AIMS protocol. So what they said is COVID-19 patients, mild disease, moderate disease, give prophylactic anticoagulation. In severe disease, use high-dose prophylactic low unfractionated or low molecular weight heparin if not at risk of bleeding. So this is how we started. Then for the mild patients, after evidence started coming of potential hazards as well, so we said if the patient does not have the patient has risk factor for thrombotic disease, then we will give. So we would give moderate and severe patients prophylactic anticoagulation. But for mild patients, if they are hospitalized and they have a risk of thrombotic disease, then we will give anticoagulation. This was our policy. And
sir, we are running shortage of time, sir.
Sure, I'm finishing. So in ICU, of course, they were more aggressive. So I want to conclude that COVID-19 is believed to be a procoagulant state. Prophylactic anticoagulation should be considered for hospitalized patients with moderate and severe disease. Hospitalized patients with mild disease should receive prophylactic anticoagulation if they have risk factors for thromboembolic disease. Intermediate dose prophylaxis and therapeutic, which is an even higher dose anticoagulation, should be instituted only with great caution. In all situations, risk-benefit ratio should be considered. Thank you very much.
Thank you, Dr. Christopher. I think we can take just 2 minutes. Just only one question. Post-discharge thromboprophylaxis, how long to continue and what are the agent of choice? Just in one sentence. How long agent of choice?
I add, whom do you consider post-discharge thromboprophylaxis?
I will start one by one. Two questions have come. So whom to give? As I said, I concluded that moderate to severe patients, you have to give thromboprophylaxis. So hospitalized patients with moderate to severe disease, you have to give. Mild patients, our policy has been, they are mild, they are in the hospital for trivial reasons. You know that very often they were in the hospital because of the governmental requirement for them to be isolated. So if they have a prothrombotic risk factor, then we give prophylaxis in those patients. So whom to give? what to give? It is preferred to give low molecular weight heparin. So we gave enoxaparin more than others. 40 milligrams once a day is the dose, which is the standard dose. Intermediate dose is BD, but I would not recommend that. So for moderate and severe, low dose or standard dose standard prophylactic dose is what we should give. And intermediate and high dose, I think still we need evidence to institute them and make sure that patients don't suffer with severe bleed because of this aggressive form of treatment.
How long? How long to continue?
Yes, okay. Well, not beyond hospitalization. And definitely, probably try not to do it beyond 2 weeks, because the study which looked at bleed said that most of the bleed occurred after 2 weeks.
So you don't recommend post-discharge thrombophlebitis?
No, I specifically didn't discuss that aspect. There are studies in that as well. If patients have been on anticoagulation, especially if they've been on higher, like therapeutic or something, whether to continue or not is a debate that is not yet answered. So one safe treatment, I'm just in the interest of time, I'm giving you a safe option, is to give aspirin. There are some studies that show that it is as good as apixaban, which is a much more potent anticoagulant. So maybe aspirin when they get discharged may be a good option.
So in conclusion, we can say that if the patient is on any anticoagulant, either oral anticoagulant or novel anticoagulant before admission or before contacting COVID, that to be continued. One. Second thing, if there is any no contraindication and the patient is having any severe or moderate disease or any biochemical marker of thrombogenicity, like 2-fold or 3-fold rise of D-dimer level, or the inflammatory marker like CRP is still high, or LDH or ferritin is still high, those patients to be covered with either oral anticoagulant, decay antagonist, or low-end or oral anticoagulant along with aspirin at least for 6 weeks, because we are seeing
aspirin at discharge. At discharge, we can consider aspirin.
And because we are seeing some patients coming back, those who have undergone CABG or stenting, they are coming with thrombotic event. And sudden cardiac death is another issue that can be prevented with these things. And there are 3 global trials are ongoing. One is REMAP-CAP, one is ACTIVE-4, one is ATTACK trial. All these 3 are suggesting, interim analysis suggesting that we should consider for anticoagulation along with single antiplatelet if the patient is having moderate to severe disease, any thrombotic event in hospital, or biochemical markers like inflammatory markers like CRP or thrombogenic marker like D-dimer is raised, those patients to be covered with both sides by antiplatelet and anticoagulant, preferably novel oral anticoagulant like rivaroxaban or apixaban. We can give these 2 agents along with aspirin, though there may be a chance of high bleeding. If we control the blood pressures and give GI prophylaxis, chance of bleeding is much less. So with this, I think, any comment from any other panelist regarding this?
Thank you, sir. We have to conclude the session and we have to go to the next session. It's already very late.
Thank you.
Thank you.
Thanks for inviting me.
Another session is there, no?
Yes, sir.
Thank you, Dr. Christopher. Thank you.
Thank you.
Thank you, Christopher, sir. Sir, this is the last session, and that is a panel discussion of life-threatening small vessel vasculitis, acute pulmonary renal syndrome, and the eminent speaker and moderator is Dr. Shyamashish Bandyopadhyay. He's a senior consultant and director of medical services, Apollo Gleneagles Hospital, and he's a very renowned rheumatologist in the city, along with Dr. Arvo Chattopadhyay, Dr. Saurabh Majhi, Dr. Satish Gupta, and Dr. Parthojit Das. Dr. Parthojit Das also is a consultant rheumatologist in Apollo Gleneagles Hospital, and Dr. Satish Gupta is a Senior Pulmonologist and Critical Care Physician in NH Howrah. And Dr. Saurabh Majhi is a pulmonologist and interventional pulmonologist in RN Tagore Hospital. And Dr. Orgho Chattopadhyay is a rheumatologist. And sir, Samasi sir, please start the session. I'm sorry for the late.
Not at all. It has been fantastic listening to some very important and appropriate discussion for some time now. I've learned many things, starting from how do we do bronchopleural fistula and so on and so forth. So welcome to the colleagues. Parthojit Orgho is chest physician wise, I think, whom we have got Asif? Chest point of view?
Chest point of view, Dr. Saurabh Majhi and Dr. Satish Gupta.
So they are also around. So Dr. Majhi and Dr. Gupta, I just spoke with Dr. Gupta some time back. And Dr. Ghosh is there. So the start is that in such a situation of a free kick in football, we always have a problem. Who will be the one? So in rheumatology, especially in areas of unknown diagnosis, we always tend to think, what is the diagnosis? So a 52-year-old woman presented with a history of fever for last 10 days with constitutional symptoms of arthralgia, headache, body ache, and mild cough. This is a very common presenting symptom in many of our emergencies all over the world. On inquiry, she had a history of polyarticular arthritis 3 years back, which was treated with Ayurvedic medicine at that time for a few months in Kerala, and she improved and she forgot about it. So the initial impression, as appropriately, was that of a recovering viral illness in ER and was admitted for observation. While in hospital, she developed cough and shortness of breath at night and found to have in echocardiogram preserved ejection fraction with increased pulmonary arterial pressure of 45 millimeter in echocardiogram. ECG at that time had sinus tachycardia. The NT-proBNP was marginally raised at 1200. Chest X-ray at the start was unremarkable. There was nothing much to find. She was seen by a cardiologist on that night and was started on some diuretic, and she improved. She had further evaluation as she was in the hospital for next day or so, and she was found to have low-grade fever. Oral temperature was slightly high, with chemosis of eye and some small ulceration on the left eye. She also had bilateral lung crepitations and bilateral small joint arthropathy. Sputum at that time came back, which showed some epithelial cell and pus cell, but Q score was -1, showing that the quality of sputum wasn't brilliant, but there were a few RBCs present in the sputum, which was at that point thought to have because of an incipient heart failure, because she recovered with diuretic a couple of days back. The sputum had no growth. The gram stain and AFB was also negative. Hemoglobin was 9.2, which was normocytic hypochromic in picture. Total count was 9,800. Neutrophil was 65% with eosinophil 8%. Platelet was 1.2. ESR was 80. CRP was high with 5.2. Our value is 0.5 as normal. Creatinine was just on the shade of normalcy, 1.3. Our value is also 1.3 in hospital. SGPT over 40 was 88. Albumin was low at 2.9. Globulin slightly on the normal range, but slightly on the higher scale, 3.8. Alphos at 120 was 145. Calcium was normal. Procalcitonin was 0.5 on a scale of 0.6 on a scale of 0.5. Ferritin was slightly high at 3,400. Fibrinogen was high at 322. INR was 1.4, which was just outside the normal range of 1.3 in our hospital. Urine routine had protein plus RBC 8 to 10. WBC was 4 to 5. There was few granular cast. By that time, serum ACE came, which was 85 on a normal value of 75. ANA was 1+ positive cytoplasmic. Both RA factor and the CCP was negative. IgG was 724 and IgM was 45, which both are slightly on the lower scale. So here, does any of esteemed colleague has got anything to ask me or put forward as any plan which you feel would be appropriate? Anybody?
Want me to start off?
Sir.
Or shut off anyway?
Yeah. Sir, here ANA is positive and urine has protein and active element with hemoglobin is 9.2 with bilateral vessel crepes. So I will go for dsDNA, ask for dxDNA and any HRCT test was done or not.
Right. Okay.
Can I comment? Because of the eye involvement, chemosis you mentioned, and an ANA which is just 1+, I think we should look for Wegener's and Anchor.
Yes.
Could I
screen needs to be done.
like to say a few words? See, basically, yes, this is a panel and our topic was small vessel vasculitis, so we are sort of homing on to the bird's eye. But say if I'm in the hospital middle of the night and this patient had come in and I've got this history that she had come in with what seemed like a bit of breathlessness and heart failure and got better with diuretic. The thoughts that would go through my mind was from the history, though this is an acute presentation, this is actually a chronic illness. Perhaps she had a history of inflammatory arthropathy some time ago. She had been on some Ayurvedic medicine, which in my book might mean some steroids, etc. And now she's more unwell. So while she might have a vasculitic or an autoimmune sort of disorder, I would still worry about infection. I note that the procal is normal, but an occult focus of infection in somebody on Ayurvedic medicine might give rise to an immune complex phenomena causing all of these features. Her primary presenting problem was heart failure, breathlessness, NT-proBNP was high, and she felt better with diuretics. So I would like, of course, CT, etc., but I'd also like an echo. We'd like to send a lot of blood cultures to make sure we are not sitting on something like an infective endocarditis, which would cause all of these manifestations. And immune profile would follow through. But I would want to definitely make sure that there's no infection with SATO.
Right here, sir. Absolutely. The echo was normal from the LV ejection fraction point of view. PA pressure was 45. No valve lesion.
Can I have some comments?
Yes, please.
Yeah. So as the topic goes with small vessel vasculitis, so most probably we are dealing with a small vessel vasculitis. But I just like to give some comments regarding the investigations available over here. So it's always better to check for like this kind of presentation of pulmonary renal kind of presentation. So with a hemoglobin of 9.2, if we have a previous hemoglobin, that can give us an idea whether there is a fall of hemoglobin or not, which can point out to the DH. Second point,
can you just repeat it again?
It is not a hypothetical patient. Okay, there might have some network problem because I'm out of Kolkata.
Yeah.
This baseline hemoglobin is 9.2. So it's always in this history and background, like patient having some shortness of breath, and in the sputum there are some RBCs. So there is every possibility patient having DH, diffuse alveolar hemorrhage. So in that background, two information is very important. What was her baseline hemoglobin? If there is drop in hemoglobin, that will one more addition pointer that probably we are dealing with a DH. And second, what was the saturation of at that point of time? If there is hypoxia and if there is drop in hemoglobin, then it might suggest there is ongoing DH, because approximately 33% of patients may not have hemoptysis as a presentation despite having DH. Second point is, can I have a look the investigation part? Yeah. So yeah, I don't know the diagnosis, but if it is a primary vasculitis, patients as vasculitis, because most of the time we expect neutrophilic leukocytosis, which is not very much evident in this case. So that is a very good pointer. And second part, which is very striking here, it's a platelet of 1.2, which is on the lower side. So that is very, very, very much odd for an active, ongoing small vessel vasculitis. We don't expect a low platelet in an active, ongoing ANCA vasculitis or small vessel vasculitis. If any time you get low platelet in a background of active ANCA vasculitis, you should think of, if it is a diagnosed case, then you think of infections and other causes. If it is a not diagnosed case primarily, then check for other etiologies. Third is the serum ACE has been checked. ACE is absolutely of no value for diagnosing any disease. It's it's neither is a sensitive test nor a specific test for any disease. So we usually don't order for ACE for diagnosing any disease. So, and third part is ANA 1+, that to cytoplasmic has got no significance, though the titer has not been mentioned here. So if primarily this is an ANCA vasculitis, there are lots of oddities in the investigation. So there has to be something plus than just an ANCA vasculitis. Thank you.
I think just one comment. I think I was listening to all the panelists. This is a multi-systemic disease, and I think it's difficult to close the diagnosis at this point. So again, infection, lupus, vasculitis is still on the board. I think probably we have to just go ahead and see what comes up next.
Absolutely.
I mean, yes, it is absolutely right. We have to go ahead and do further investigations, but I have to treat the patient at the moment. So what would you do for that? Because all your other tests are going to take some time to come back. So I mean, that is why I said it is very important in these cases to make an early diagnosis. But I think sepsis is the killer. So you have to investigate for sepsis, treat empirically for sepsis while you wait for your other tests to come back. And yes, since this patient has a multi-system sort of presentation, you got your cardiac involvement, you got eye signs, you got some lip changes, you got your renal active sediments, you got lung involvement. What Saurabh had suggested, if you get a CT, if you can see some more alveolar damage, because we've got some RBCs, but that might be from some oral lesions, etc. It doesn't necessarily tell you diffuse alveolar hemorrhage at this stage. So the question I would like to ask is, would you just throw in the antibiotics, or would you throw in the antibiotics and steroids while waiting for the results, or would you wait?
So, right. Okay. That was very lovely discussion. So let's see how it panned out. Now we are sort of day 5 into the patient's admission into the hospital. Day 4 actually into the hospital. And patient had a course of antibiotic, fairly humble one, was on ceftriaxone and doxycycline as a starting point, because the initial ER impression was that of a recovering viral illness. So they started on some monosef and doxycycline, which was continued, not upgraded, seeing the procal wasn't very high, the count wasn't very high, patient wasn't in hospital before. She came with a history of 10 days, and also she for last 3 years she had been fairly okay with history of some inflammatory arthropathy which got recovered. And I'm completely in agreement with Dr. Gupta that Ayurvedic medicine to me is always a pack of steroid. So she must have a course of steroid at that time in form of Ayurvedic medicine, and she got better and forgot about it almost. And then she came with, as Saurabh said, that she came with this feature which was not obviously typical. No illness actually in real life comes with typical findings. But she came with, so to say, a multi-system condition with involvement of multiple organs, including mostly kidney and lung. So obviously vasculitis was on the cocktail, on the pack. So after that, we had a CT chest, which was done, which had showed bilateral GGO with small cavity lesion in right middle lobe with some nodular shadows. The ultrasound showed hepatosplenomegaly. By the time the SPEP came, there was no M-band. The ANCA was positive with anti-PR3 strongly positive in her case. So we had a diagnosis. I accept the point that normally platelet count is high and low platelet is either associated with thrombotic thrombocytopenic purpura associated with ANCA vasculitis. But yes, that was something odd. Whether or not she had Ayurvedic medicine induced suppression of bone marrow, whether she had a viral illness which triggered everything else and the platelet got low, I don't know. I don't know the answer. Subsequently, platelet did pick up, which is not in here. So with the diagnosis of polyangiitis vaginalis, we started on injection with prednisolone, and we gave the first dose of cyclophosphamide because she was 52-year-old. So the family wasn't a problem. She already had a family, and she had good improvement. So while on this 3 days of initial 1 gram methylpred in the ward itself, she never had a major saturation issue. So saturation was hovering around 97%. We never took her to ICU at that stage. Patient deteriorated, and she had a fall in the saturation. ABG was type 1 respiratory failure. So we took her to the ICU. She was put on NIV, and we obviously repeated the infection screen as Shodhisa pointed out before. We had further blood culture, urine culture, and sputum culture, and which are all sort of initial bits were negative.
Yeah. Fairly standard scenario what we see. So this patient had a reasonably good sort of diagnosis of vagueness and was put on the appropriate treatment. Patient had some basic antibiotics going on. Now the patient has deteriorated. Cardiovascularly, how is the patient? Blood pressure and things are okay.
They were okay. They were okay. Just a respiratory, mostly a respiratory problem. As somebody said that, there was obviously a bit of hemorrhage must be in the GGOs were hemorrhages. So she went down, went on NIV. But my question is, obviously, that do we need any other test or anything else or what? Any suggestion?
Yes, sir.
Parthojit, are you there still?
I'm there. I think probably just a repeat chest X-ray might confirm.
Yeah, we did an X-ray in the ICU after the NIV. It deteriorated from the initial X-ray, which was unremarkable at the starting point. The emergency X-ray was unremarkable. The CT on day 5 did show the GGOs and the nodular shadow and some cavity lesion. We did not have X-ray after that because we started the treatment, but obviously on NIV X-ray did deteriorate to some extent, but not complete whitewash. I must say, not complete whitewash.
I've got three differentials here.
Yeah.
One is the elephant in the room, sepsis, always setting in. This is 5-6 days. And do we need to upgrade the antibiotics? Second is whether the person's thrown a pee, because since patient is hypoxic, he's unwell in bed, etc. And the third is that this patient has had the disease for some time, which has probably been masked by the steroids in the Ayurvedic medicine, and is perhaps not responding as well to the current treatment that is being given, and that it is a little bit resistant at this stage. These are the three things that go through my mind. And now we have to systematically approach these three. So yes, I would like a CTPA sort of thing, a D-dimer, which may or may not help, a venous Doppler of the legs. I think that the patient might already have been on some prophylactic anticoagulation. If we find anything more, we would do that. For sepsis, more cultures, bronchoscopy, lavage, the escalation of the antibiotics. And the question about resistant disease not responding is the other one which will be there. But the patient's already on methylpred and patient's already on cyclophosphamide. At this stage, we'll have to probably persevere with that. And if the patient continues to deteriorate, especially renal function and the hypoxia, then we might consider further immunosuppression or even plasma exchange.
Shavash, do you have the CT films with you?
No, I don't. Actually, I did not have time to upload those things.
I was just thinking whether.
Don't tell me there was a pneumothorax or something.
Another differential is maybe have myocarditis also.
Yes.
This is induced
So
or
what happened in the ICU, which is fairly standard in our ICU or any ICU in the planet, the patient had a repeat chest X-ray, patient had venous Doppler of the leg, patient had a repeat echo, and patient had the infection screen and had sent a repeat procalcitonin, repeat a D-dimer, a procalcitonin, D-dimer, white blood cell count, and urea electrolyte and sodium potassium, those things.
LDH said?
No, I don't think LDH was done.
Or a repeat CT?
No, repeat CT was not done, just an X-ray was done. So in those cases, Doppler was, I'll just tell you the questions which has been raised by Shadizda. The Doppler was normal. There was no venous thing. There was, the D-dimer was of the tune of 800 odd. So it was not contributory given the acute illness picture. Platelet count by this time has recovered to 2.2, most likely after the methylprednisolone. And the white blood cell count went up to 12,000, most probably after methylprednisolone. And otherwise, there was just worsening. The patient was okay on NIV itself. We did not need to ventilate the patient. We asked one of our respiratory physician whether we should get a bronch done or not. But because of the NIV and the respiratory failure, it was being proposed that the bronchoscopy might lead to ventilation. And patient family did not give consent for bronchoscopy post-bronch ventilation possibility. They were very afraid of ventilation, so we did not try bronchoscopy. So at that stage, we have sent few other tests with these what I have mentioned, and we did send an anti-GBM antibody. Because of the renal impairment which was there, we did say anti-GBM antibody, which came out to be positive with worsening the renal function and anemia. The hemoglobin went down, the urea creatinine went up, and anti-GBM antibody also came positive. So here we have a double positive pulmonary renal syndrome. Now we all know in the rheumatology field that normally MPO is positive in this sort of double hit situation. But here PR3 was positive, which is rare, which is possible, but fairly rare. So it was a double positive pulmonary renal syndrome. We thought of plasma exchange and FFP plasma exchange, but we did not need it because with the ongoing cyclophosphamide and the steroid, patient gradually improved and came out of NIV, etc., and subsequently on steroid and mycophenolate in OPD follow-up. So thank you very much. I know it has been very late. Good that I had a small presentation, and further discussion is open to the panel if you still have some steam left.
No, I mean, I think that was a very good case that you presented. I enjoyed the discussion, even though it's sort of 11:15. I mean, I always feel that, especially in our country, infection has to take priority over everything. And I think Dr. Orgo mentioned that if you see that there's a history suggestive of vasculitis, other systemic manifestations, if you see a dropping hemoglobin, if you see deteriorating renal function and protein and active sediments in the urine, one has to consider this pulmonary renal syndrome and send the relevant immunology. Though the gold standard is biopsy, we seldom get biopsy in the acute stage. If you're lucky, you've got a lot of skin involvement, you can ask somebody to take a bit of skin biopsy, which will give you the diagnosis later. But if you suspect one of these, then in addition to antibiotics, you will have to hit them with immunosuppression, which is usually methylprednisolone and cyclophosphamide. It's a standard for many years, though people are using newer drugs, but they generally try to use them when these don't work. But in your case, lucky, patient did not require ventilation, did not require dialysis, got better with the methylpred and cyclophosphamide.
I wanted to highlight that we if the patient would have deteriorated, we could not have given possibly rituximab because the IgG and IgM both were low in her case. So giving rituximab would have been a problem in this case. So plasmapheresis would have been the next choice, as I think,
especially with the IgM, with the
NPO
GBM.
Orgo, do you think we have just been lucky that we did not need to give plasmapheresis?
But probably at the current stage, plasmapheresis is just the patient has anti-GBM. That was a plus point. Otherwise, probably in today's date, plasmapheresis is not going to help a lot in ANCA vasculitis.
Yes.
And I beg to differ in one point, like regarding the rituximab. So, as per the recent guidelines and European Society guidelines, the IgG level of more than 6 you can go for happily with rituximab. And if it is less than 5 with infection, then think for supplementing immunoglobulin and then give rituximab. Otherwise, in more than 6, probably we need not to worry much if patient require. In this case, the patient did not require anything. So probably we are lucky in this patient.
Because I was of concern that if cyclo and steroid doesn't work, the choice between plasmapheresis with plasma of huge volume, which is a lot of expenses. In comparison, rituximab is a lot cheaper. So whether it will be cost effective to actually take a consent and give it, but then thankfully,
and it's more effective.
And I mean that was a concern. Saurabh, what's your view?
Sir, here the rituximab is I will give the rituximab will be more because now the recent guideline shows, as the Dr. Orgo says, the recent guideline shows the plasma exchange is not much benefit. Only the selected patient they are beneficial, where the involvement is not much severe. In case of the moderate patient, they are beneficial, but not the severe patient. The plasma exchange is not so much beneficial. So rituximab might help here.
So thank you. We still have got a lot of people. So it was really interesting. Thanks to all of you. We had lovely fun.
Thank you.
And I'm sorry, Shatishda, I could not mail you because I just
It's okay. It's always nice for it to be impromptu. I did not know what format it would take, but you said it was the case, so that's fine.
Good.
Thank you.
It's wonderful to see you after a long time.
Yeah. I wish we could do it in person rather than virtually.
হ্যালো সতীশ, হাই।
হাই দাদা, নমস্কার। ভালো আছেন আশা করি?
হ্যাঁ, ঠিক আছে, ওকে, নাইস টু সি ইউ।
ভালো লাগলো অনেকদিন বাদে সবাইকে দেখে। সৌরভকে তো কোভিড এর মাঝে একদিন দেখেছিলাম আমরা হাসপাতালে এসেছিল। ভ্যাকসিন নেওয়া আশা করি সবার হয়ে গেছে, ফার্স্ট ডোজ।
We are all vaccinated.
Good.
ভ্যাকসিনে কাজ হবে কিনা সেটা এখন বোঝো।
মনোবলটা বাড়বে সেটা তো ডেফিনেট, কিন্তু নেক্সট ভ্যাকসিন শুনলাম
প্রথমটা কোভিশিল্ড, যেটা উনি বললেন না, প্রথমটা কোভিশিল্ড, পরেরটা স্পুটনিক নিলে সবচেয়ে ভালো কাজ হতো।
চাঁদে পৌঁছে যাবো।
একটা হিউম্যান একটা শিম্পাঞ্জি হলে ওই ক্রস ইয়েটা হতো না আর কি।
Okay, so
Asif, can we leave now?
Yes, thank you everybody. So we are concluding a wonderful session which has been going on for last 2 days, and wonderful exchange of thoughts, education, upgrading, whatever you call it, and we will certainly do these things once again in near future. Thank you.
And I've got a back pain. I have to tell Asif to give me something.
Thank you, sir. Thank you.
We give you a thumb on your back for a good work done.
I want to share one thing, sir. Yesterday we have concluded our session at 9 o'clock, and till 9 o'clock there is a 800 participant today also.
Wow.
So it is a wonderful session, and everybody till 11 o'clock, everybody is watching our program. So it is a very successful program. We want
Thanks to all the speakers and the panelists. Thank you very much.
Thank you for inviting.
Thank you.
Good night.
Thank you.
Good night.
Now I will give vote of thanks. Vote of thanks to first the Apollo Clinicals Hospital. Apollo Clinicals Hospital that given us the opportunity to arrange such a wonderful session, and I also thanks Cipla Critical Care for giving the technical platform and support, and special thank to Satish Sai SR, the marketing head of Cipla, and Mr. Anirban Chatterjee is regional head general manager of Cipla Critical Care, and along with I will give special thanks to this Mars Auxiliary Academy. They have done the all backup work for managing the faculties, sending the invitation and program design and all. And I will also thanks there are multiple companies who has spreading the news. Though we have keep our registration absolutely free, and they have helped us to print the materials and spreading the news to the nursing practitioner, medical college, students, and different hospitals. And for this, I will give thanks to Regenius Movie, Allergy Fusion, Redcast, Mylan, Sanofi, Greenfields, and Cardilla Pharma, Pfizer, Redmark, Aculif, United Biotech, Caspi, and Sun Pharma, and Cipla Respiratory Divisions, and Abbott Critical Care. They have supported a different way to make it successful. That's why there is so many registration. We have a 1200 registration, and yesterday the participant was 850, and today till now is a report saying that more than 800, and till now the live participant in attending session is more than 400. So it is a great pleasure for me to that we are doing this is a very successful program, and we hope we will do in near future the physical meetings, and we have upcoming meetings that in the month of June, first week of June, that is IRCCM, International Respiratory and Critical Care Medicine Conference, and that time we will do both platform. Virtual as well as the physical, and we will hope we will meet again, and that time we will not only virtual, we will also be a physical. Thank you.
Time.
Okay. Thank you very much. Thank you, everybody.
Good night, Shivashish. Good night, Ashok. Good night, Asif. Yeah.
Thank you, sir.
Nice to see you.
Yeah. Bye.
Thank you, everyone from Powers Academy.
Thank you.
Thank you. Thank you.